Bienvenidos a todos a una edición más de PlanetTalks. En esta ocasión tenemos al doctor Laurence Klotz, que es una eminencia en el mundo de la urología, de la investigación en cáncer de próstata y de la cirugía uro-oncológica, y considerado prácticamente el padre de la vigilancia activa y también del diagnóstico con micro-ultrasonidos. So welcome, Dr. Laurence Klotz.
Thank you.
I just said that you are a very, very big shot in urology and uro-oncology. We all know your work, and you are professor of the Department of Surgery of the University of Toronto and the chair of the GU Prostate Cancer Researchers. Am I right? Or
Well, I hold a chair of prostate cancer research at Sunnybrook.
Okay.
And I have been a chief of my department. Not anymore. We have 10-year terms. And I have a few other hats which I can go into.
Okay, perfect. So, as this is a chat that will have mainly aimed to young urologists, what were your first memories about when you first decided that you wanted to be a doctor?
Well, I come from a medical family. So my mother's father, my maternal grandfather, who was born in Russia and fled Russia because of pogroms towards the end of the 19th century, came to Toronto about the age of 6 and actually was one of the first Jewish graduates from the Faculty of Medicine, University of Toronto. It was quite unusual then. And so on my mother's side, my grandfather, my father was a urologist. And so I have an uncle who's a dentist, another uncle who's an endocrinologist on my mother's brother. So I had a lot of examples of successful physicians. My uncle was in fact a world famous endocrinologist in the area of Graves' disease. So I was one of those kids. I decided early on that I wanted to go into medicine. One of my hobbies is music. I play the piano. When I was around 18, I went to my piano teacher, who I revered, and I said, his name was Freddie. I said, Freddie, what do you think about my having a career in music? And he said, well, sure, you could do that, but why don't you come down and see me play? So I went down, and he was playing in this horrible Chinese restaurant. No one was paying any attention, and I thought, that was a wake-up call. I said, I think I'll stick with medicine. So I was sort of inspired from an early age. Of course, the last especially that I thought I would go into was urology, because my father was a urologist, and in those days, this was the 70s, like it was all about, the kind of youthful rebellion, which I participated in to a degree. But eventually I decided that actually a year or so out of medical school, I had an experience in a rural hospital and where I started actually do something with my hands, which was mainly tooth extraction. Mm-hmm. Everyone had rotten teeth in this little community in northern Newfoundland, and I would help give the anesthetic, and then the dentist would hand me the pliers, and I started pulling out the teeth, and that was the most fun in medicine that I'd ever had. And suddenly I realized, doing things with your hands has an element of joy to it. Mm-hmm. And actually, I think that's something we don't communicate well enough to students, is the joy of surgery. When you've kind of mastered how to do an operation and you go in and do it, the patient gets better. It's really a joyful experience that the non-surgical specialties don't get. So the light went on in my head. I thought, okay, I have to go into a surgical specialty. This is too much fun. And then I thought, the fact that my father's a doctor, that should not be a reason to avoid urology. So here I am.
Perfect. So you worked for medical school in Canada?
Yes.
And then you did your residency in urology?
Yes, I trained mainly in Toronto, and then I had some training in McGill as well. We only in those days had 3 or 4 major centers in Toronto. There wasn't that much to choose from. And then I went to Memorial Sloan Kettering as a fellow, and I was profoundly influenced by Willett Whitmore, who was probably the first full-time urologic oncologist. And he was the chief at Sloan Kettering, and I was there right at the end of his working career, but he had a huge influence on me.
And how did you manage to know him or meet him, or you
Well, I worked with him.
Yeah, but you wanted to go to Memorial for your fellowship at
Yes,
first?
so no, he came to Toronto as a visiting professor when I was about a second-year resident, and I was just blown away. And because he had such a different approach to oncology than anyone I had ever worked with. Evidence-based, straightforward. You know, I was trained as a resident, you don't use the word cancer because that is just too devastating for people. You use these euphemisms. You have a little growth. Whitmore, it was all out on the table, and it just seemed so much more transparent. And he was also a voice for conservatism. So, you know, there's these phrases called Whitmoreisms. One of the Whitmoreisms, probably the most famous one, is is treatment necessary when it's possible, and is it possible when it's necessary? In other words, you can cure the patients who have indolent disease, you can't cure the ones who have aggressive disease. So that he embodied what I call surgical oncology humility, that the major driver for outcome was not the great surgeon, it was the biology of the disease. Yeah. And that was a revelation for me. And I think nowadays it's become completely accepted that disease biology is the major determinant of how patients do. But that, in those days, that was a novel concept.
We'll talk about it later, but maybe that's a good ground for active surveillance.
Sure. So I can tell you about that whole journey, which was quite, I would say, extraordinary. So you have to go back to around the late 80s. PSA came in, and that just coincided with the start of my career. PSA came in about a year after I went into practice, and everyone is familiar with those incidence curves where PSA comes in and suddenly, boom, spectacular rise, unprecedented rise in prostate cancer diagnosis. And the interesting thing is that in the era when TERP was being done on everyone, because there was no alternative treatment for BPH, it was about 10% of patients were found to have small volume, it was called low-grade prostate cancer, grade 1 prostate cancer in those days, Gleason 6. And there was this very widely accepted idea that, you don't treat that. And, you know, I was trained as a resident, when you see small amount of low-grade cancer, either you don't tell the patient, or you tell me at a few slightly abnormal cells and you follow them. So that, in retrospect, was a very advanced concept. No one's really commented much about that. But I knew that in my mind. And then PSA came in, and boom, we started diagnosing all this prostate cancer, and everyone was getting treated. And we have data from that era, meaning around 1995 to 2010, that 95% of patients with low-grade prostate cancer were getting radical treatment. And a lot of things fueled that. Pat Walsh had described nerve-sparing radical prostatectomy. Pat Walsh said and wrote with great conviction, he believed if you did a radical prostatectomy, you got a positive surgical margin, you were wasting your time and you were harming the patient. The only point of doing the operation is if you had a very high chance of getting a negative margin. Who had a high chance of getting negative margins? Gleason 6 prostate cancer. So his view was that the ideal patient was Gleason 6. And so everyone was treating these patients. And I was part of a multidisciplinary group at my hospital, and we had a tradition that about every 6 months, a few of us would go out for lunch together, and we assigned ourselves a challenge. At the end of the lunch, we should come up with a study or a trial. So this particular lunch, there were 3 of us, me and 2 radiation oncologists, and we said, what can we do about, we're clearly over-treating these patients. How can we do something different? Let's just try not treating them at first. We'll watch them, we'll track the PSA, we'll re-biopsy them, we'll treat the ones that don't look good. None of us thought that this would have any impact. And at the same time, there was a new grants organization called the Prostate Cancer Research Foundation of Canada, just started. They had their first grants competition. I submitted this grant. We got the grant, $35,000, the only grant they gave out. And we set up a prospective database to track these patients, hired a data manager to track the data. That was the key thing. And if there's one kind of message to come out of this is, if you're interested in a topic, set up a prospective database. You don't have to randomize, you just collect the data. How did these patients do? That was the key thing. So after 5 years, so we started that around 1997, 2002, we had 250 patients and no deaths. So we published it. We didn't know what to call it. Expectant management, we used all kinds of terms in the first publication. And that publication created a very intense reaction. So many people thought this was harmful. People said it was unethical.
Right?
People, and I mean, that evolved over time. But, you know, here we had 250 patients, no deaths. Like, how can you improve on that? So we were fueled. And also, a lot of other groups jumped on this. So Hopkins started about a year after we did, UCSF. So there was a small group of people. It was a bit like, you know, the Bolsheviks and the Mensheviks in Russia before the Russian Revolution. We were the Bolsheviks. Like, we were a small group, but we really believed. And so that started a firestorm. And we kept accumulating patients. The other interesting thing was, first of all, you can imagine 20 years ago. You see a patient and you say, yes, you had your biopsy, it showed prostate cancer, but you don't need any treatment. And the patient would look at you like, I could see what they were thinking. This guy's a lunatic. Like, I have cancer. They have to treat it. Why is he not offering me treatment? That, amongst other things, has changed quite a lot over the last 20 years. People are much more susceptible or much more aware of this idea of indolent cancers, of overdiagnosis, overtreatment, and so on. So from 2002 to 2012, it was about a 10-year span, this topic was really hot and controversial. And the prostate cancer, the eminence grises, you know, the senior people in the field, who I idolized, including Pat Walsh, Bill Catalona, a number of others, they sincerely believed that this was wrong, that active surveillance was wrong. And there was a period where whenever anyone was organizing a meeting, they said, listen, how can we really get some action, some sparks at this meeting? They would put me and one of these guys on the podium, which from my perspective, I mean, here was I, a junior guy, unknown, and I'm on the podium with Bill Catalona, you know, who was the guy who first described PSA. So from my perspective, it was great. The other thing about me personally, I had always liked debating. And when I was in high school, I was on the debating team. When I got to university, I kept debating. It was just purely a hobby. And I was actually the president of the debating union at my university. I don't know why me, because there were other students studying law, political science, much better than me, but that doesn't matter. But I had learned the skill of debating, which includes things like how to think on your feet, how to turn tension into humor, how to have a fast comeback. I never thought that would do me any use. What use is that in medicine? Medicine, you're treating patients. That was huge for me because I was able to kind of take these guys on, and I was kind of comfortable public speaking. So it turned out, you know, you never know in life what influences are going to be useful, but that turned out to be really, really critical. So we did that for 10 years, many debates, meetings. The whole concept gathered momentum. And then 2012, the US Preventive Service Task Force came out and said, forget PSA screening because there's too much overdiagnosis and overtreatment, which is what I'd been arguing the whole time. So that basically was the end of the debate. And then it was, okay, we better adopt this approach. We're going to throw out the baby with the bathwater. We better start accepting active surveillance. So then the debate about whether this is right or wrong was over, and then it became, for the last 10 or 12 years, there's still lots of debate, but it's, you know, how to do it, what's the best protocol, how can we expand it to intermediate risk, all those issues, imaging, biomarkers. No one anymore is contesting the principle. And then I'll make one more anecdote in this whole story, which is I was at the ASCO meeting, which is this gigantic oncology meeting. Like, I think it's the largest meeting in the world. And I see there's a session on overdiagnosis and overtreatment. I thought, okay, that should be interesting. So I go, and it turned out it wasn't obvious from the title. It was about overdiagnosis and overtreatment in breast cancer. So I'm in this room with 2,000 people that I don't know. They're all breast cancer doctors. And they start talking about preventing overtreatment, and they start showing my data. And they say, listen, these guys in prostate cancer have figured this out. We have to adopt this, mainly for ductal carcinoma in situ, where it's a lot of the same issues. So I was just like flabbergasted. So I thought I have to say something. So at the end of the talk, I walked up to the mic and I said, look, I just want to introduce myself. I don't know anybody here, but my name is Dr. Klotz. That was my data that you were looking at about the active surveillance of prostate cancer. I got a standing ovation. So there are not many guys in our field where you can get that kind of appreciation from another field that you're not involved in at all. So that was kind of the story. I thought, wow, this is something.
Well, that's a hell of a story with those breast cancer. Okay, so you told me that you were fascinated about doing things with your hands. You love surgery, and you start talking about not doing surgery to those patients. There was something inside you that was like a little bit heartbreaking, or it was just...
No. Well, so of course, I mean, part of the resistance, there were two reasons why people pushed back on active surveillance, in my opinion. One was they genuinely thought that people needed to be treated. If they weren't treated, they would die of prostate cancer. And there'd been some data from like Johansson's paper from Sweden, 15-year follow-up, where it wasn't active surveillance, but it was conservative management. At 15 years, a lot of patients started to die of prostate cancer. So, you know, one of the criticisms early on was you're reporting too soon. You wait. If you wait, patients are going to start to die. And by the way, Dr. Klotz, those deaths are going to be on your shoulders. It's your fault. Pretty tough. So they were wrong. We've now got 20 plus year follow-up. There's no mortality cliff. Patients actually, the longer they're on, the less likely they are to die of prostate cancer. And the second reason was if the cynics who think that doctors are just driven by money and they just want to build their practice and operate on anyone they can. So like a lot of these things, of course there's an element of truth to that. I don't think it's fundamentally true. I believe very strongly that almost all doctors want to make their living doing the right thing. They don't want to make their living doing the wrong thing. They like to operate. Surgeons like to operate. But they like to operate knowing that it's going to be for the patient's benefit. So, and I think another aspect of this, Canada has been a leader in a number of areas for conservative management. Testicular cancer, kidney cancer, prostate cancer, other non-urology areas. And I think it's because we have a kind of unusual system in Canada, which is a more or less socialized healthcare system, single payer. There's a lot of problems with our system, but one of the benefits is we're not like over incentivized to operate. You can make as much money seeing patients in the clinic as you can operating, and everyone's busy. So it was not like any kind of sacrifice, I didn't think, to say, look, we should stop operating on these grade group 1 patients. First of all, there's still lots of patients to operate on.
Yeah.
So, and second, look, why are we here? We're here to improve the health of patients. We're not here to operate just for the sake of operating. So I never had the slightest qualms about that.
Okay. You said something about 2012, the U.S. Task Force recommendation, that I don't know if I agree. I mean, what you were doing was avoiding overtreatment.
Yeah.
But not overdiagnosis.
No, but
you were diagnosing better than
correct. Well, so those are two somewhat separate things. The task force said the problem with screening is overdiagnosis and overtreatment. But 2 years later, roughly, or maybe 3 years later, they changed the recommendation from D to a C, mainly because of the adoption of active surveillance. So, of course, there's also concern about overdiagnosis, and that has obviously shifted. We use PSA a lot differently now than we did 10 years ago. So I think probably both were part of that change in the task force perspective on this.
Okay. Okay, so you were a pioneer in the diagnosis and treatment of Gleason grade 1, and some years after you start with micro-ultrasound.
Yes.
You were like very fond of ultrasound usually in your practice, or started?
No, it wasn't about that. I did ultrasound guided biopsies, but systematic biopsies. So I never really looked at the ultrasound as a diagnostic test. I use it to guide the needles. No, so the story, how I got involved is, as it happened, the micro-ultrasound was invented at my hospital. Mm-hmm. So the story is, I had a basic research lab for my whole career. And I had a weekly lab meeting in the research building with my research people and graduate students. And so one day, this would be, I don't know, 15 years ago, maybe more, I was coming from my lab meeting and I was waiting for the elevator. The elevators were slow. Waiting for the elevator, there's a bulletin board with all the announcements. And I see this guy is talking about had developed this ultrasound microscope. And I was looking at studying murine orthotopic prostate cancers. So we would induce prostate cancers in these mice, usually by implantation, and then studying the effect of various influences like diet, exercise, micronutrients, some old drugs. And so this group upstairs, there was a big research imaging group, had developed an ultrasound microscope, which allowed you to to actually image a 0.5 millimeter cancer in a mouse prostate without killing the animal. So I thought, this is absolutely fantastic. So we did a whole bunch of studies with them, studying the growth of these cancers over time. It never occurred to me, my blindness, it never occurred to me that this might have any use in humans. Like, there's no value that I can think of in finding a 0.5 millimeter tumor in a human. If for no other reason, the evidence from breast cancer particularly is that humans are developing these tiny cancers all the time, and then they disappear. Talk about a risk of overdiagnosis. So I never thought this was going to have any clinical application. But the group, who is led by this brilliant engineer, Stuart Foster, developed this device for clinical use, high-resolution micro-ultrasound. So I had a relationship with his group. I knew the guy very well. So he came up with the first version. He said, listen, we want to try this out. Phenomenal. Like, I mean, another I would say, theme of my career that is I was always looking for collaboration with non-urologists. And that was just an example where I worked with the guy using his ultrasound microscope, and the next thing I know, he's offering me this incredible tool. So I got one of the first actual approved devices, and as soon as I started using it, like the light went on. Wow, I'm seeing things that I never saw with conventional ultrasound. And so, you know, we worked together. The thing went through a number of iterations, and you know, to me, this was literally, not literally, this was like manna from heaven. I never anticipated this. Suddenly we have this phenomenal machine, which I rapidly developed expertise on. And you know, the rest is history. I mean, this device is now going all over the world for good reason, I think, because it's very appealing technology.
Yeah, and I don't know if it's luck or destiny, but you're both discoveries, I mean, maybe stick together now, because as active surveillance in grade group 1, you cannot follow them with MRI a lot of times because you don't see the tumor in MRI. Maybe with micro-ultrasound, you can follow those patients too.
Well, they're complementary. Mm-hmm. I'm not sure, I mean, the data we have, which is now pretty substantial, there's a group of patients who are visible only on micro-ultrasound, not MRI, and vice versa. Okay. There may be a few more that are visible only on ultrasound. It's like 25% only on seen that are missed on MRI, seen only on ultrasound, about 15% only seen on MRI. One of the interesting questions to me right now is why? Like, what is it about a cancer that makes it visible on one of those technologies and not on the other? We have a lot of data now about radiogenomics of invisible cancers that show it's very, I think, powerful concept that the molecular alterations that make a cancer visible are the same genetic alterations that make it a more aggressive cancer. But is that the same for ultrasound? Like, what's going on? We don't know. I'm not sure it is a more overall, like it's a more sensitive test. Does have very high resolution. Who knows? Yeah. I use them together.
And when do you get your confidence to use it as a screening tool? I mean, to just perform an ultrasound and be...
You mean after how many cases?
Yeah, more or less. Or when in your life do you start to see that you can, not only, of course, you can perform the MRI, but the micro-ultrasound is a good tool and you are confident with it?
Well, I would say, so you have to understand my learning curve coincided with kind of the learning curve of the overall experience with the technology. So early on, you know, I was learning how to do it. I would say it took 2 years before I had enough confidence, and that's partly I put together the data from the first 11 centers in the world who started using it, and it looked as good as MRI. that wasn't perfect because not everyone was blinded. I mean, if you see something on MRI, you can find it on the ultrasound. Yeah. If you're blinded to the MRI, it's a little more challenging. But once I had the data from those 11 sites, got published a few years ago, and other groups started reporting the same thing, then I switched. So I would say it was a transition, but unequivocally, beginning about 2 or 3 years ago, I said, you know, you just look at it from a resource perspective. You compare patient with elevated PSA, goes for his MRI, gets the co-registration, gets the fusion targeting, comes back for his biopsy, a lot of resource. Versus what I do now, I don't do an MRI. I only do a micro-ultrasound, and I only biopsy them if the micro-ultrasound is positive. And they just come in. It's transperineal, so there's no antibiotic requirements. There's no extra prep. They just come in. They have the micro-ultrasound. If the target's there, I put in the local xylocaine, do the biopsy. One stop for the whole thing, and patients love that. And if the biopsy's negative, I still follow the patient. You know, I maybe a couple of years later do an MRI because I like to alternate them. But that has really, I think, facilitated the whole diagnostic pathway. Like they don't need the MRI. They don't need 2 visits. It's really very appealing.
And do you think those active surveillance patients could benefit from that
so an
behavior?
Active, yeah, well, first of all, it's not just the micro-ultrasound that's influencing that. So the imaging has had a huge impact in active surveillance. So I have some publication that's just going to come out in the next couple of months where we looked at how our active surveillance patients did before and after MRI was brought in, which was 2013. Up to 2013, we had about a 3% prostate cancer mortality rate. Low, but not zero. Since 2013, we incorporated MRI. We have not had a single patient develop metastatic disease out of about 500. That's amazing. And what that says to me is the patients who were doing badly before are the guys who had a lesion that was high-grade cancer that was visible in the MRI. So it works. And so, yeah, so we've moved away from biopsy. If the MRI is negative, we basically don't biopsy them, and ultrasound. And then I alternate MRI and ultrasound. And yes, if there's progression on the MRI or the ultrasound, they get a biopsy. But it means the biopsy is maybe every 5 years or less. Some patients don't get one at all after the initial one, or they get maybe a second and that's it. You think back, Hopkins was doing a biopsy every single year on patients. And some people looked at active surveillance and said, how can you biopsy patients every year? Well, we never did that.
Take it out.
We never take an excisional biopsy. We biopsied the kind of average patient maybe every 3 or 4 years, but now it's even less than that. And of course, patients don't like biopsies. So, you know, I think that's...
because sometimes in our media, we have a lot of centers that are doing MRIs, and not all of them are expertise centers.
Well, that's another issue.
Yeah, so...
Yeah, well, of course, that could also be an issue with ultrasound. We have a lot of data on MRI interpretation, how variable it is. There's some interesting papers showing that actually if you compare machine learning interpretation of MRI, like AI, to experienced radiologists, they don't do as well. We still have radiologists, not artificial intelligence, interpreting our MRIs. So, you know, MRI is getting better. AI is going to help. I'm sure that's going to be incorporated. There's all these other ways of interpreting, of analyzing the pixels, different kinds of spectroscopy, and very advanced techniques of pixel analysis that make it more sensitive. So MRI is not going away. And I don't mean to imply that micro-ultrasound is going to replace MRI at all. I don't believe that. But I think for the initial assessment of patients who have like mild elevation of PSA, it's very appealing.
Okay, one last question.
Yeah.
What would be your advice to a young urologist that is fond of uro-oncology and robotics and surgery nowadays?
Well, so let me just talk in a more general way, which is how to optimize your chance of success in science, in a scientific career. And there's a lot that I think everyone knows. It helps to be engaged and have an inquiring mind. Persistence is very important. You know, active surveillance, we started this program more than 25 years ago, and you keep at one area, and as I said, music is one of my hobbies. I don't consider myself to be that talented, but I've been playing the piano so long that I know how to play. And so, persistence in life is important. The other thing that I think is not appreciated as much is, I call it the schmooze factor. Schmoozing means talking to people. So you go to a meeting as a young clinician, scientist, clinician, investigator, and you go to one of these huge poster sessions, and there's 200 posters, and there's some guy standing in front of his poster, and no one is paying him any attention. And he's also a young guy, and you go up and talk to him, you look at his poster, ask him a few questions. And then 6 months later, you're in another meeting, you're in the same boat, you're standing in front of your poster, and he comes up to you, and now you recognize each other. And after a couple of years, you've got a shared interest, you have a friend. And it doesn't take long. It's in the blink of an eyelash, he's the chairman of his department. And now he's running a meeting. And he has to think, gee, who should I invite to this meeting? And you're the guy on his list because you have this relationship. And look, I think life is about relationships. It's also about productivity, science, publishing. But I think what differentiates those people who work hard, make a real contribution, publish, but never quite get up to that level where they're kind of on the circuit, on the lecture circuit, and become a name that people know, has to do with cultivating the relationships with your colleagues. And I'll just make one more point about this. Even though this whole relationship thing was something I never appreciated. I had to learn this on my own. But you go into academic medicine and you find your area, whatever it is, and you have colleagues all over the world who are spending their days doing pretty much exactly what you are. They have shared interests, they're treating the same kind of patients, they're doing research in the same area. And I have close friends in my region, my hometown, but those people who are interested in exactly the same thing I am, they become some of your closest friends because you share so much. And that adds a richness to life which you don't get in other areas. And it means you have friends all over the world. You go and visit them. You get an entree into that society. And that's something you don't get so much if you don't go into academic medicine, because it's kind of the research that is driving that international interaction. So, this is just something I would encourage young people to think about, is really keep at it and work on developing those relationships, because that really it's part of, it's a key to success, but also it's personally very gratifying.
Well, I can testify that because last year in AUA Chicago, I was in a poster session of genomics, and you were there.
Okay.
And it was moderated by Francesco Montorsi,
Oh, yes,
I think
sure.
Catalona too. And I saw you going up the stage and with no poster, just talk to people, and everyone was listening. And it was like a great lesson.
Yeah.
Not so many graphics and so many Kaplan-Meier.
Right.
Sometimes the message and
Right.
and the talking of someone like you, it's really interesting. Thank you very much, Dr. Klotz. A real pleasure.
Pleasure. I hope people find this discussion interesting. I enjoyed it.
Thank you very much.
Good.